Good morning, everyone.
Morning,
Welcome
everyone.
to today's staff brief.
Thanks, Danny. Morning, everyone. Welcome to this week's and the first staff brief of 2022. So, Happy New Year to everyone. I'm Paul Robinson. I'm the Chief Executive at Sherwood, and I've got Peter, Dave, Julie, and Simon with me. You can all introduce themselves. If you would take first place, Peter.
Thank you, Paul. Good morning and Happy New Year. I'm Peter from Clinical Engineering, otherwise known as MEMD.
Dave.
Hi, I'm Dave. I'm the MD.
Julie.
Hi, Happy New Year. I'm Julie, Chief Nurse.
Hi, I'm Simon. I'm the Chief Operating Officer. Happy New Year.
Great. Well, today we'll be reflecting on the current pressures we're experiencing and how we're planning to respond to those. But firstly, I'll hand over to Peter, who's going to talk us through the changes in thermometer use from next week. So, Peter, over to you, please.
Thanks, Paul. Lovely. Yes, folks, it's just really an update that next week the trust-wide rollout that will last 3 weeks in total, switching over and exchanging the thermometers away from the eardrum tympanic membrane ones we've got so used to the new axilla, armpit or oral sublingual thermometers. So I'm here on behalf of Tracy Stilling, her funder there as the Trust's lead for medical device training. Just to very quickly summarise, this is tried and tested technology, been used in paediatrics for many years, and it's easier to keep clean. It gives a wider thermometry range, measurement range, and it's more reliable on the measurements. The calibration doesn't drift so much, all that sort of thing. So it's really all those clinical effectiveness reasons that have rationalised why we're doing this. The existing agreement expired. It does actually also save money. The plastic covers are less expensive, and actually we create less plastic waste, but they're not the deciding factor. It's been driven right from the start by clinical. So you'll either see it manifested like this, especially early on, as portable hand-alone units that go into a docking station, a wall docking station. There's a QR code that you can scan, on your mobile phone to bring up the training competencies and materials. So I'd encourage folks, please, to try to delve into that if you possibly can. As the team come round to you with the programme already shared, they will reinforce and be there to really help you and do the actual switch. We've just welcomed ward staff, please, to facilitate that, help with recovering the old tympanic Genius thermometers and any surplus stock of probe covers that need to be managed. And if you haven't already nominated a local Cascade trainer, I would encourage you, please, to try and do that and let Tracy know. Really, we're very confident this will provide a much better measurement performance, much more accurate and reliable for you, the clinicians. In a nutshell, that's about it, really, Paul. Is there any questions or?
Dave's got a question by the look of it.
Yeah, Peter, thanks. And I know this does bring us in line with other local organisations as well with this swap, because that's happened, I think, over the past year or so elsewhere. But certainly working on the critical care unit, the old tympanic membranes, I used to regularly hear them fall off the tables, crash onto the floor, and they weren't awfully robust, and they used to break quite often. Are these ones a bit more reliable or a bit more robust, do you think?
Yes, I think they are, Dave. I mean, basically the tympanic was great in its day, wasn't it? It's the ultimate sort of in point and shoot and give you a measurement. The reality, though, is they're optical instruments, they're infrared based, and they take very unkindly to any tumbles or falls. I'm not saying these are, tank proof or whatever, nothing is, but this is a metal sleeved probe, which I'm trying to sort of put into the angle there, slender probe, and will be more robust and certainly more reliable.
Great, thank you. So if anyone's got any questions on the rollout of those thermometers, please put them in the chat now, and I'll just come back to Peter, because Peter, going to give you an update on beds and an order that we've placed and what we should do in the meantime.
Thanks, Paul. Yes, it's just briefly to share. Probably no surprises. Obviously, mirroring the super surge that we're going into. That actual hospital bed frame, profiling bed frames are slightly in short supply at the moment across the trust. So an urgent order is being placed. We were looking with Claire Madden, the lead on the equipping side and other aspects of the project, I'm sure, to acquire some from the National Emergency Hospital pool, but they were deemed to be clinically unfit. Basically, you couldn't move patients in those beds, so that raised larger risks. In the interim, please I just encourage all areas, if you have a bed surplus or broken for that matter, just report it in the normal way promptly, and my teams will get it taken off you and try and get it turned around urgently. The other issue is realistically sometimes the handsets break on the beds. If it's the patient handset, we would normally pull that out of use, wouldn't we? At the moment, I think just operationally in the next sort of few days, we may have to raise a temporary technical concession where we leave that bed in use if the nursing handset is still in use. I obviously, interested to hear whether, in particular, Julie, you've got any comments on that sort of approach. But
thanks, Peter. I think we need to take a patient-by-patient approach to that, because clearly the risks of leaving a very vulnerable patient on a trolley is not good either. So I think there are patients that we can identify that be more suitable to be on those beds. And I'm sure that Claire will work with you as part of that.
Yes, indeed. Thanks, Julie.
Okay, thank you, Peter. Danny, do we have any questions that have come in for Peter so far?
Not as yet, no.
Okay, well, if you've got any questions specifically for Peter on those, excuse me, two specifics there, then please put them in the chat, and also use the chat for any other comments or queries that you might have as we move on to sort of more general reflections on the current pressures we're experiencing, and the decisions that we've been taking in order to respond, and decisions we may take in the future. And just start by thanking each and every one of our amazing employees and staff and colleagues who've incredibly challenging holiday season, and this continues into the new year, and with an expected Omicron surge in the next couple of weeks in the Midlands. As you're probably aware, we've got 100% occupancy of beds, and we've opened additional capacity, and our number of COVID positive patients have doubled since Christmas Eve, and we now have over 100 patients testing positive in our beds. And this means that we've had to take lots of important and sometimes difficult decisions, not least regarding visiting and restrictions in reapplying some of those restrictions around visiting that Julie can update on. And just reiterate my thanks to each and every one of you for your hard work and commitment in ensuring that patients get the treatment that we can provide and keep them safe while we're doing that. Clearly, we have workforce loss at percentages that are higher than we've ever experienced before, or certainly did last January. So I understand the pressures we have in terms of maintaining safe rotas, and thank you for everything you're doing to help in that respect. Simon, do you want to cover any specifics around the decisions around additional occupancy and capacity that we've got in place?
Yeah, thanks, Paul. I mean, as Paul's described, we are in the middle of a COVID surge. It started as Paul described, on Christmas Eve we had 44 inpatients who were COVID positive. Yesterday we had 113. So in just over a week, that has more than doubled. To put that into context, in January of 2021, when we saw the Delta wave, there were 200 patients at the peak. So that's very high already. And we are expecting this to get worse over the next 2 weeks in the Midlands. It isn't translating into critical care as yet. I think that is a bit of an unknown at this stage, and that's a positive thing. Colleagues will remember that our #1 priority this winter was to safely reduce demand on critical care and give them a little bit more sustainability. And the respiratory support unit, and a huge thank you to colleagues in respiratory and estates and across medicine for their support with that unit, and orthopedics actually, who've moved to facilitate that. Has opened, and that's really positive in terms of some patients who would have gone to critical care now going to respiratory support unit, and of course the enhanced care bays on Ward 31 are supporting elective patients who may have previously gone to critical care. So at this stage we're not seeing the surge within critical care. I think that Paul described what NHS England will call a super surge plan, but essentially it's opening capacity in areas we wouldn't normally open. There's been a plan developed around that. Some of that plan has already been enacted. So the discharge lounge was moved to Clinic 6, and the bedded areas on the discharge lounge have opened as an adjunct to Ward 36, which creates 8 extra beds there. And the cardiac catheter lab is supporting inpatients as well at the moment. So huge thank you to those 2 areas. There are further elements to that plan. I think there's still some details to be worked out around that. So, you know, we're really at the limit of where we've ever been before with these things, because of course in previous COVID surges we've had lockdowns, and that has suppressed demand coming into A&E in different ways. So some of that wasn't a good thing, because some people didn't turn up who should have done and were poorly, but also it suppresses other infections because of reduced sort of like people being close to each other socially. So this year we really are pushed to the limit, given that we have all the other work to do and all the other patients to treat on top of that. I think I reiterate Paul's thanks for that. So, you know, our workforce loss is obviously higher than it's ever been, and we realise that leaves a pool of colleagues left behind who are trying to cover, and the flexibility and dedication that everyone is showing to support that is incredible, and also to look after patients might not normally be looking after. And you might have read in the media some other trusts have been declaring incidents around this, and that's mainly been related to workforce and not having enough colleagues to sort of look after patients, and we haven't quite been in that boat yet. So thank you for that. I would just say though that ED is overcrowded every day, and that is a real risk when you've got such a transmissible illness as COVID, and particularly in terms of the Omicron variant. And we really need to do all we can to be able to get some flow. I know there are a high number of medically safe patients trying to get out into packages of care and the like, and our colleagues in social care are hit with workforce issues as we are, but we are running a real risk in that area. That said, ED are doing an incredible job to turn ambulances around, and whilst our ambulance turnaround times have increased slightly, they're nowhere near where some other trusts are. So doing an amazing job around that. And just to give a bit of a context, ED was at 148% of its capacity on Monday, which is something that we don't allow to happen in any other area of the trust. So we really need a whole trust effort and response to where we are at this moment. We are in a very serious position with regards to this COVID surge. That's all I wanted to say, really, Paul.
Thanks, Simon. I was just sort of looking in the chat, making sure that we'd covered off some of the comments, because there was a question about added capacity that has been open, and I think you've covered that. I'll ask Julie about the lateral flow tests. There's a question about what other areas might we use if the surge continues. I think I don't think you were specific where that might be, but we're looking into all those areas that may be used for inpatient facilities. Is there anything you might want to update on that, Simon?
Yeah, so endoscopy is an area that is being looked at in terms of that use. There are things being looked at in terms of Minster day case around that. And they're the two other areas at the moment that have been worked up, but there's still work to do to develop those, and obviously to work with colleagues in those areas about how that would work safely, whilst trying to continue to treat cancer patients and to treat other poorly patients who will need elective care. So, you know, we cannot stop doing elective care. We cannot go back to where it was 2 years ago, where a lot of things were stopped. So they're two other areas, but it might not end there. And we'll work with colleagues in those areas to identify the areas and ensure that they're made as safe as possible.
Thank you. Dave, Julie, have you got any comments to add to those, and especially for my information, how we are assuring ourselves of the safety of those areas that are being opened in that super surge plan?
I'll let you go first, Julie, if you want.
Yeah, so in terms of the super surge plan, this was pulled together with the heads of nursing, the clinical chairs and the divisional general managers. Each of the areas has been through a quality impact assessment. There was originally a list of about 12 areas, and 7 of those were deemed unsuitable for patients to be put into. So it has been through our incident control team, those quality impact assessments. And I guess the biggest blocker to opening capacity at the moment is staffing. So we do have a twice daily staffing meeting for nursing, midwifery and AHPs, and Dave has a similar daily meeting for the medical staffing across the organisation. We've got agreed minimum staffing levels that we operate on a day-to-day basis. We have agreed an exceptional workforce plan, and some of you will have seen some of the situations that have been described in local organisations with nurses looking after large numbers of patients. We have a support rota should we get into difficulties with meeting minimum staffing levels, and that means there will be senior nurses on site 24/7, floor walking to support the rounding of patients as well. So I can see somebody's asked us what proportion of staff are currently off with COVID. And Dave's very good at remembering the stats on that, Dave. Is it 10.8% workforce loss?
So the total workforce loss is 10.8, and it was 10.1 this in the peak last year. But that's all total workforce loss. We've got 578 colleagues off in total. I think it's 347 off with COVID. So it's round about 5 to 6% off with COVID. And again, that's reflected in a number of our local organisations, although our ambulance services are finding they've got a very much higher workforce loss than we have, which adds to many of the pressures for the whole of the healthcare community.
Thank you.
I was just going to a couple of things. So Simon chairs a daily instant meeting where we take the decisions to consider what areas we need to open or don't open. As Julie says, we've got a whole series of daily groups meeting to try and balance the risks of doing something different against the risks of what we're facing, and that's taken it to the most senior level with the people on this call. I think in terms of the Omicron, we obviously are watching very closely what's happening in London, and we haven't yet peaked in the Midlands. The prediction, if I've got this right, is that London obviously went first, and then it's more towards the northwest, and then the northeast, and then it's going to be the Midlands. That's the sort of prediction. So we're just waiting for that peak to come in. It does seem to be predominantly a younger age group. again, which reflects the sort of South African experience. What we don't know and what we're watching London for is to see whether it then jumps after a week or two into the older population, and that would be sort of any time now that we'd start to see that. And again, there's usually a lag into critical care, and London haven't really seen that huge critical care impact as Simon was describing. So again, that's just something that we'll be watching. And then I guess the only other thing I would just highlight is that to encourage anyone who hasn't had either a first dose, second dose, or a booster to go along to our vaccination centre. They won't chide you, they won't criticise you, they won't be judgmental. They'll just support you to get that. We are seeing significant available space in our vaccination centre, and partly that's because over the Christmas New Year period we've had about 20-25% of the booked appointments not actually turning up, which is really disappointing because we are staffing these areas in preference to some of our other services to try and ensure that not just our colleagues but actually our citizens and patients also get the opportunity to have this. So I'd encourage people, if they feel that now is the time, or they've been wondering about it, to go and get a vaccination.
Yeah, thanks, Dave. Yeah, I would echo that strong encouragement. I was on a sort of a Midlands-wide call yesterday, and the medical director for the Midlands described Omicron as mild, but only where an individual has immunity. Where an individual doesn't have immunity, then Omicron causes severe symptoms. So something that I think hasn't been as starkly explicitly mentioned in the press, because I think the press have latched onto mild symptoms, but only where there is a strong case of immunity in an individual is that the case. And indeed, our vaccination hub is open each day. From today, actually, it opens at 8 o'clock in the morning and closes at 2 p.m. in the afternoon. So that's a change to the times that were published yesterday in the blog that I sent out. And you can walk in, get your vaccination there, but the last time for a walk-in is 1:30 p.m. So I'd encourage everyone to ensure that whether it's first, second, or third or booster, that you get that vaccination. Okay, thank you. So I'm also looking at the chat. So Julie, can I ask you to talk to us about visiting and the arrangements that are now in place, and also there's a question about lateral flow. So if you could pick up lateral flows, the fact that the library doesn't have a stock of them, and what we're expecting staff in terms of their regular testing regime to be. Thank you.
Thank you. So many of you will see that we made the difficult decision to pause visiting from New Year's Day this year, and that's because we'd moved from a position where we had COVID cohorted on a small number of wards to COVID being quite widely dispersed through the hospital and an increasing number of outbreaks. We made the decision to keep patients safe, but also to keep the local community safe, because vulnerable people coming in here could easily be contracting COVID as a result of their visit here. We've agreed it for a 2-week period. It's subject to the normal, what's the word? We're still allowing end of life visiting. We're still allowing visiting for patients who require a carer. So if they've got mental health difficulties, learning disabilities, or they usually have a carer, then we are permitting those to come in and support the patient's care. We'll review it in 2 weeks' time and take another view on whether that restriction needs to remain in place. Maternity visiting for now remains unchanged, as does paediatrics. And the emergency department, we've never really been able to reopen visiting because of the limited space for social distancing in there. Outpatients remains the same, so we are encouraging virtual visits where we can, but where it's face-to-face, patients should come on their own unless they require a carer or a parent. In terms of lateral flow, so I know the announcement last night from Boris was made around daily testing, but for NHS staff, this hasn't changed. So we'll still be asking you to test twice weekly at the moment. We will get another supply of lateral flow tests for the library, but it's fair to say we aren't getting a huge supply of these in. So you do need to order via the government website as usual. I'm told that it's easier to get the kits in the morning, but that the website is updated every 30 minutes. So you may need to persist in trying to get them. We will have a small stock on site. We do have a stock for colleagues who have tested positive and need to test on day 6 onwards to see if they can return to work on day 8 or later if they've got 2 negative tests within a 24-hour period. And when you have your positive result, the team will let you know how to get those. I saw a question about military support. At the moment, we don't know if we're getting military support. It isn't a hospital specific request. There is a Midlands request that's gone in and we should hear any minute now, but this won't be the silver bullet that saves us, because it will be a small number of military personnel like we saw in the last peak. So in the last peak we had 12 and then 8. So it will be a help if we get it, but it's unlikely to save us. So we are looking for people to volunteer to support clinical services in a different way. And that is being coordinated by Claire Madden, who sits in my team.
There's a few there. I'll pick up, Paul, if that's okay. So there's a question there. Any thoughts on changing outpatient services? So outpatient services will have already been reduced in some areas. The sort of principle behind that is we will reduce outpatient services to free up colleagues, particularly medics, to support inpatient services where necessary and where they've got the skills to do so. So that's already happened, particularly in the Division of Medicine. But other than that, we'll keep outpatient services going as much as we can, but, you know, particularly in areas like ophthalmology and so forth. And then there's another question about the private sector. So we do send patients to the private sector currently for their surgery. We're trying to send more. Obviously, we're doing that in partnership with Nottingham University Hospitals. So there are patients who will get their elective treatment in the private sector. The private sector do not want to look after patients who are medically fit for discharge. We can't get them in a place where they're able to do that at this time.
Thanks, Simon. I'll pick up a couple of the questions as well. There was a question about flu uptake. The last time I saw the numbers, we have 75% of our frontline staff vaccinate with the flu vaccination. There was a question also about working from home and communications around that, or correspondence. That hasn't changed, so we encourage all staff who can work from home to work from home as much as they possibly can. Agree that with your line manager. Obviously, we need to ensure that our services continue and that each individual is supported to work from home appropriately, but please do that. There's a question about staff who are vaccinated or unvaccinated. We're able to identify from our records who we think which staff haven't received the vaccine, and we've contacted each one of those members of staff. In some cases, staff have been vaccinated elsewhere, and we're updating our records, and we're having discussions with individuals who are either hesitant around the vaccine or indeed have over the last 2 to 3 weeks received their first vaccine, because I understand there've been a steady trickle of individuals walking into the KMH vaccination hub for their first vaccine, which is good news. Julie, are you able to pick up the under 16 question?
So there was the under 16. So yes, you can bring, if your child is between 12 and 16, Dave, they can have the vaccination in our hub. The second question was, if I've got a positive lateral flow, can I still come to work? That's a no. And then confusion around why are we advising people to retest on 6 and 7 when we've previously said they shouldn't test for 90 days. Confusion about the science behind it. I think it's fair to say a lot of us have had that view, but that is the national position. Dave, do you want to add anything?
So I think this stems from this particular variant. So what we seem to be finding with the Omicron variant is it's highly transmissible, but the viral load is relatively low in many people, not in all people, but in many people. And so that's the idea about detecting whether you're still excreting virus. So with the original variants, you did have a very long excretion period, and you also had a long excretion period of in effect dead virus. But with the Omicron, it seems to be much shorter, which is the rationale behind that. Does that make sense?
It does. It does. Just going to pick up another one. I have COVID symptoms, but so far negative on lateral flow. Should I take a PCR? Yes, you should. You can book your PCR by contacting the vaccination centre helpline. And then another question, if I'm admin and not clinical, should I be doing LFT? If you're coming onto site, you should be lateral flow testing. We have had outbreaks in non-clinical areas. How long after someone has had COVID do they need to wait for a booster, please?
Oh, is that for me? Gone. Who was saying there?
It was me saying, is it 4 weeks?
Yeah, I think it is 4 weeks.
Yeah, it is 4 weeks. Okay, and if you're positive on lateral flow test on day 10, can you still come back to work? You can't come back to work until day 11.
But on day 11,
to have a conversation with occupational health, you need to be asymptomatic for 48 hours, no temperature. So you need to have that conversation with occupational health.
Thank you. And then there was a comment around work placements, I think, on apprenticeships, was it? It's now disappeared, but it's just they've been suspended for the month of January, was it?
Yeah, that decision was made by the incident control team yesterday.
And again, this is to reduce the unnecessarily footfall within the organisation and exposure to a risky environment as much as we can. And we will review that at 4 weeks.
Thank you, Danny. I think we've covered off all the questions or comments.
I think so.
Are there any sort of closing comments that anyone would like to make for our wrap up today?
So, I mean, I would reiterate just that massive thank you, Paul, to all of our colleagues and our teams. I think it's fair to say that we really thought it would be quite tricky over Christmas and New Year. It usually is in recent years, but we thought particularly this year it would be exceptionally tricky, and so it's. I think it's fair to say so it has been. What I would say is that I think it is probably quite normal now for people to feel a bit run down and a bit frustrated by all of this, and actually, where is this all going? I think there is light at the end of this tunnel. The evidence that we're seeing to date seems to suggest that this next wave will be much shorter than we've seen in previous waves. So we hope that January is going to be a bit rocky and a bit bumpy, but once we get into February, then actually many of the traditional services that perhaps we've adjusted will be bringing back and will be working in a more normal fashion. Now, what then happens after that, I think that's difficult to say, but Omicron has been in the community for so widespread now that a very significant component of the population will be affected by that, and you'll see that the government theories are that then that should give a much greater immunity to many more people, along with the vaccination programs. We still don't know what will happen with future boosters or all of those aspects, and we, like you, continue to watch and to listen intently with the latest guidance that's coming out. But I think whilst the start of January isn't great, I think there is some reason to be a bit optimistic going forward into 2022.
Thanks, Dave. Peter, Simon, Julie, any closing remarks?
No, I'd just like to echo thanks, especially thanks to my team, how they've pulled together over the last couple of years. It's just really lost for words in a way. Well, I am, but no, echo that wider thanks across the board. Thank you.
Julie?
Yeah. And I'd just like to say the same. I think, as Dave said, I think things are going to get really could get quite difficult, even more difficult than they already are. But we will be side to side with you, making sure that we do our very best to keep patients as safe as we can and that we look after you. I would encourage you to raise any concerns that you might have with us. So thank you.
Yeah, just reiterate that. I don't know if you can hear me, Paul, because I've got a bad network problem.
Yeah,
but
I can.
Yeah, just say thank you so much to everyone on this call and beyond. And as Dave was saying, I think there is hope that this could be shorter than previous surges, so it might be intense, but it might be short as well. And we hope that's the case. Please do keep flagging up where you're concerned now. Freedom to speak up, all of those aspects for your line manager, because we want to hear where there's risks and do everything we can to manage it as best we can. So thanks so much. Keep going.
Yeah, thanks to all today, and I just wanted to ensure that we looked after ourselves and look after each other, and just remind everyone of the Boost Wellbeing package that's available. Gave the link in the blog yesterday. It's also in the intranet. Raised concerns, as Simon mentioned, and just as a sign off today, and another thank you. We can't say it enough. Thank you to each and every one of our amazing staff here. It could be a very difficult January. It could be a short sharp peak, and into February we see something much more positive. Whatever January looks like, the only way we'll get through it is by supporting each other. That is critical. So support each other, and we will support you to do the right thing and keep patients safe. So thank you for attending today. Thank you for all that you're doing, and we'll join you again next week. Bye.